Hello, everyone, and welcome to the Quorum Podcast. This is where academic medicine meets remote, austere, and resource-limited areas. Welcome back to the program. This is Aebhric. This week, we are with Anke Krug, who is a community nurse working in Nunavut, Canada. Anke, welcome to the program.
Hi, thank you.
So, tell us a bit about yourself and what's keeping you busy.
Well, the Arctic, especially the Arctic, is really busy. We have to work collaboratively with a lot of people within Nunavut, and in different areas as well. But we definitely keep busy with the basic needs of the community, but it kind of evolves into something more. We do end up medevacing or emergency evacuation for our clients when we're unable to provide the care that they require at the time. So every day is different. Every day is different. We run regular clinics from 9 to 5, but we're pretty much open 24/7, and that can definitely keep us busy in a place such as this, for sure, just based on the issues that the clientele have.
So you started out as a medic, not the paramedic level, but you started as a medic with doing a lot of trauma, and then you became a nurse. Is that right?
That's correct. Yeah.
So how long was your nursing program?
My nursing program, I was, when I started quite some years ago, we were able to complete the program within 2.5 to 3 years. And it wasn't a degree at the time, but now that's advanced. And now to graduate as a registered nurse, you do have to have a bachelor's within the nursing degree. But I didn't stop pretty much. I went to work right away. And in fact, over the course of like maybe 10 years, the last 10 years, I completed pediatric critical care advanced. And then I also completed remote nursing. And so I came up essentially with a double major within the nursing program. And that was just recent, 2 years ago. And but during that time frame, after I graduated from the diploma program, I worked for about 10 years in pediatrics in British Columbia. And but I I loved a little bit more adventure, and I saw an opportunity to become a Medevac nurse within Nunavut, which processed me into becoming a community health nurse here. And I've worked all over the North, which is pretty exciting stuff.
Wow. So you have a degree in remote nursing.
That's correct. Yep.
Fantastic. And you have done Medevac, or you do Medevac nursing as well as being a community nurse in an austere environment in Nunavut.
Yes. There's a little bit of a difference. Like to actually be on the flight. Yes, I did a contract to be on the flight Medevac to bring clients to and from remote communities, and then to Kikatani in Iqaluit, and that's a higher center. And that's what I did. But being now in community, I initiate Medevacs and I prepare the clientele for transportation.
You package the patient.
That's right.
And how cold are we talking about when you have to package the patient to get them out of your hospital or your clinic and into the fixed wing aircraft. And you're in far north.
That's correct.
So how do you deal with that?
Well, I mean, we face a lot of things. Depending on where you are, you can be as low as like -60 with a wind chill. And essentially, yes, I prepackage them, but the medic that comes to us to pick them up, they'll actually transfer, excuse me, to the aircraft themselves. But I have in cases transferred them to the plane as well. But some of the things that you really have to think about is your IV solutions freezing, making sure that they're warm. Like they have to stay close to the client so it stays warm. keeping them protected from the cold environments. But another thing that I learned the hard way is that make sure you have gloves, because the the metal frames of some of our stretchers, you put hands on, and you're basically you just froze your hands. So preparing yourself for transport is also another consideration.
No doubt,
Yeah,
because if you're to minus 60, like I've only been to minus 40 in northern Canada or in northern Alberta, and that was mental.
yeah.
So you just step out and then you're immediately cold. I imagine your casualties cold as well. How long does it take for an IV bag solution to freeze in minus 60?
Minutes, like less than minutes. Yeah, you can. I mean, if you've ever seen some of the clips, there's people that actually throw tea or water within the climate, and it immediately evaporates, and it's a very interesting phenomenon. So the you're in sub-zero temperatures, and it's immediate. So you're going to start to get crystals within the IV solution.
Wow. So what other considerations
Crazy,
do you
right?
need to think about when you're working in that environment?
Well, again, you have to consider the IV therapy. You need to make sure that your client is safe from all any environmental influences, because the thing is that there's also frostbite, frost nip. These are all considerations, and even oxygen flow. You got to make sure it's slightly humidified, or it's warm when you travel. So we have to consider the O2 tanks, how much flow, and we also have to consider moisture.
Wow. How do you warm the oxygen as it exits the canister? It's got to go through what 30 millimeters or sorry 30 centimeters of piping, and yeah, how do you keep that warm?
Well, you actually can pipe the actual line under the client themselves. Like, so say for example, or under the packaging. So you put the entire line along their core, and you put the tank between their legs, and that can stay warm. You also have to think of the pressures too, and how much oxygen you have left. Now, I don't know exact numbers how that works, but yeah, you also have to consider that. And then on top of that, you're dealing with the ice crystals that could form within the mask themselves, or even via the nasal prongs. And so you oftentimes actually have to cover up the client from head to toe, and that's a bit disturbing, especially when part of your assessment is seeing the client. And yeah, so if you're not used to not doing that, you need to. Yeah, it's tough. It's a very tough call.
What other considerations do you have to change when you're dealing with this environment?
Well, I mean, speaking of the how do you monitor a client from kind of like a distance, in a sense. You also, I guess, you also have to consider the type of teams that come up to transfer my clients, because they have to be well aware of these conditions, and it's a big deal. We use a lot of telehealth communications to speak with physicians, and to see what we can get away with for safe transportation. So, do we really need an IV to flow? Can we lock it off? Can we consider, if possible, bagging a client versus using an actual unit? It's or a ventilator. You really have to. These are some of the critical discussions that we have to have with our transportation.
Wow.
So it's a collaborative effort.
Is it flat or is there an elevation change you have to worry about as well?
Well, I mean, we're dealing with the tundra. I'm from BC, so everything it looks like hills to me versus mountain. Um, but a lot of them can be, quite hilly, and so communication could be an issue. At the beginning of when I started, there was no cell service in some communities. There was just absolutely nothing, and so we had to work with Duraphones, or we had to work with VHF. And it really, with the hills in the way, communications, even with a satellite phone, are impeded. So these were difficult hurdles that we had to work with. And there was a time that I did not have any service whatsoever. So my satellite service went down, the electricity was down, computer system was down, and I had no landline to use, and that was a very scary thing. That was a very scary thing to deal with, and you're all on your own. So you have to work with battery backups, and yeah, battery backups. You have to consider how long my batteries last for a prolonged client. You have to know all these little details, and these details, they when you experience them, it's like, oh my gosh, I'm never gonna forget that. Which then you evolve to a different level. So when something like this happens again, you kind of have an idea of what to do.
Wow. So are you working solo? Or are you in a clinic, or how have a hospital close by, or how does this work?
Well, our main within Nunavut, there's several different places that are considered more of a tertiary center. Rankin Inlet is one, Iqaluit is another, and we have communications with other provinces such as Manitoba as well as Ontario. Our nearest higher level is are those two places, but we are considered a nursing station, and that's a little hard for people to understand because it's mainly manned by registered nurses, and that's how we started. But it's gotten to a point where we've actually introduced other paraprofessionals, and these they range from licensed practical nurses, obviously registered nurses, but now we're moving into an advanced paramedic and nurse practitioner level, and we have to work collaboratively, excuse me, to meet again the needs of the communities, and it's been difficult. It's been very difficult to kind of uh, um, find that balance, but it's evolving. So from when I started to now, which is I'm going on almost, oh gosh, when did I start? I'm going on 20 years up here. It's definitely changed to something more, and it's exciting to see those changes. It's really exciting to see those changes, especially from a girl that started in a higher tertiary center to all the way up here. I never dreamed of being able to work up at this capacity.
Wow. So you have advanced paramedic slash nurse practitioner level that you're working on, or you're trying to implement. And can you touch on the education for that? Is that a master's level paramedic, master's level nurse, or is there a difference between the advanced paramedic or the nurse practitioner?
There is a difference. There is a difference. A nurse practitioner is, again, this is a little bit of a different concept between what you would consider a nurse practitioner down in the southern regions than one within the Arctic. Nurse practitioner up here has the ability to uh, um, order certain services to refer clients for diagnostics or on that level. Excuse me, and they're also allowed provide to provide prescriptions as well. And but the nurse practitioner role within the Arctic, again, is evolving. A lot of people are doing remote nurse practitioners, which we can access. So we have more ability to do more. We can do more that is a little bit easier to access. So they can follow certain clients here, and oh, excuse me, I'm losing my train of thought. The advanced paramedics, again, they're new, but they can bring a lot of information that some nurses just, haven't had the experience of, like uh, uh, traumas, cardiac. And although the we have experienced nurses within the ICU, within the emergency that are up here, the paramedics bring a totally different aspect on how to basically prepare for potential chaos. We have so many roadblocks when we transfer a client. You can have them for days up here and have a very unstable client. And so these certain paramedics have actually helped me organize my health center to a point where I'm ready should any of this happen. And I'm a huge advocate uh, preparation. And in fact, a lot of the stuff that we've taken on, like austere medicine, holding on to a client, ICU capabilities, we've made these changes so we can handle it. And plus, with the evolution of a telehealth, having a doctor pretty much within the room with us remotely allows us to do that, and that says a lot. That says a lot. So our motto is pretty much control the chaos should chaos occur, because we're so prepped for it.
So how big is your hospital?
Okay, I'm gonna say I'm a nursing station. Hospital is goes into more of an austere kind of environment. I am in a community of 500, and I started here with only one other nurse. Yet now, because of the depth of scope, uh, I've required more, especially with all the things that I'm starting to see. So I ask for paramedics. I ask for an extra nurse. I've now got, I'm trying to get a licensed practitioner, not licensed, LPN, excuse me, to be all part of my team on a continuous level. But it's not so easy sometimes because not very many people want to work in the Arctic. And it's very nerve wracking to work up here because there isn't that safety net of being in a tertiary center.
Yeah. So it's just you.
Yeah, it's just the nurses. Yeah, that's it.
So how far away is the nearest trauma center?
Well, the next tertiary center to me is Iqaluit. However, you have that also in Rankin. So it it's what I would call a puddle jump, but we're still very hard to get to because of environmental winds, availabilities. So essentially, I'm 35 minutes from that center. But again, it's very difficult to get people transported there because it's such a vast area to cover.
So you would, if you had a major trauma, you would stabilize at your community center, drive them 35 miles in austere environments to a trauma center where then the plane would land to collect them after stabilization. Is that right?
No, actually, I'm a fly-in only community, and there's no roads here, so it has to be by plane.
Wow.
Yeah, I'm really hoping that we can evolve a little bit more and bring a rotary, uh, uh, like to implement a rotary Medevac within the Arctic. But there's a lot of work to be done. There's just a lot of work to be done.
You would think that financially a helicopter would be better, easier to use on those short hops than having to get two flight lines set up with the fixed wing capability.
Well, I'm trying to prove the concept, right? And again, I require the information so I can present it in a fashion that I can show that it's a financial boon for us. So that's actually in the works. But yeah, in some cases it is about money, but we're also dealing with the lives of clientele, and so, we're in a place now where we can look into these factors, we can look into these possibilities because we're now in a place where there are options now, and again, it's really exciting to be part of that, to be able to pioneer it.
Can you discuss on how you make the decision to either treat and release your casualty?
I love my job.
Oh, brilliant, brilliant. Can you discuss how you make the decision on whether you treat and release a casualty versus transport?
Well, we have guidelines that we follow, and we follow those very strictly. But again, there's a lot of communication with physicians, and again, it's a comfort level. As I'm not really too keen on keeping, you know, a this the person that's here sees the stability, and we have to be able to have that communication to be able to portray that to a physician that cannot necessarily see the client. Now, uh, but the thing is that technically, based on my staff, I can't necessarily hold on to a client, or I shouldn't have to hold on to a client for more than 4 hours, because again, we're not a hospital. So if it goes beyond, like, if if it goes beyond our capabilities of 4 hours, we request for transportation. But it can be, sometimes it can be very simplistic, but other times it can be, we know that we have to leave them because they need ICU care, or they need one-on-one care, or they need more of a hospital setting for their care. So it's again a collaborative effort that you have with the physicians, and the communications with us, and our policies.
Have you used the prolonged field care guidelines or the website?
Um, it's kind of it's new to me that these guidelines are there. Again, we've made do for so long, and to be introduced for austere medicine, it's a new concept, but not a new concept. Like, we've been doing it for years, but there was never a name for it. And so now I have a name for it. And again, we've been doing it for years, but now with seeing that there are guidelines that I can apply to, again, it's made us better. So I am familiar, but unfamiliar. I'm still learning.
So how did you find them? Is it somebody did somebody else put you onto them, or did you do a Google search and find the PFC guidelines?
Um, Yes, actually, it was through the introduction of paramedics that I found these guidelines, and I am so grateful that we've kind of opened the doors for paraprofessionals, because that's how we learn. So yes, I did learn it from an advanced paramedic, Cole Shaver, that came to our community as an advanced paramedic, but we had some pretty big discussions on what this looked like on a more on a higher level. So he was able to introduce the guidelines to me, so I could share it with other people, but to also prepare better for the worst. When essentially, before, it was like a let's figure it out on the fly, and I don't like I like the intensity of being able to kind of think outside the box. But I also like the fact that there's people that have done this before, and they have found what the best practice is. And so I'm very thankful that he came to our community, because he's definitely brought us to a different level.
Wait, so how did Cole Shaver, who works in the far north on the west coast, how did he wind up in Nunavut?
Well, the call went out for advanced paramedics because there is a nursing shortage everywhere, as we all know, and the in a lot of cases, nurses were taking are taking a lot of the burden, especially up here. And so they considered a concept of bringing the medics up here, and because I'm so small, and again, I need to have medics that really know their stuff. He was part of the group that came up, and he landed in my neck of the woods. And there were a lot of interesting conversations uh, and discussions on how to make us better. And I'm always for making something better, getting new ideas and applications. So this has been a big boon for us here.
So, what training or academic programs do you see that your clinic, your staff need that work in your clinic?
Well, see, I have several people that, I've got front staff that work with the administration and the medical travel and such. But I really feel that everybody has any input, and so uh, my front staff know how to um, get an emergency room prepared when we have something during the day. So we have actually managed to bring get a merge ready with the telehealth communications, with X-ray on standby within 90 seconds of a client arriving. And that's something I'm very, very proud of. So for training, it's an ongoing thing. Whenever an opportunity arises, but we're still faced with the fact that we are limited in our time, and so uh, our sometimes our training comes from people such as Cole coming up and showing us what the latest and greatest is. So the training is online, or if there's a possibility to go to conventions or potentially go to training classes, we would love to take the opportunity, but it's not without some barriers to get there. It's a lot of it's done via electronically and through telehealth.
So, what kind of medical cases and trauma cases are you seeing during your shift?
Well, medical cases, I can't really talk too much about it, but essentially a doctor's office is what it is.
Hmm. General practice.
Yeah, general practice. We do have the ability to do basic lab work. Some of our some of it has to be sent out, and that again is a challenge because shipping of a lab is also a challenge, be it be it freezing or even being too warm. Um, we have remote and basic BRTs, which they're trained. These are local community members that have been trained to operate uh, the machinery to do that. But again, it's basic. We recently being over the last few years, upgraded. I used to have to process the actual films by hand, uh, but now we've upgraded to an electronic system where we can send these X-rays to a tertiary center, and that's helpful. And again, traumas of every kind, anything like be it falling through the ice or an MVA, you see it all. You see it all.
I can't imagine having to do X-rays and dipping it in the solution to get it to develop. Wow.
Yeah, it's crazy. Like I had to go into we have a lot of us have developing room. We still have the red light. It went from dipping the solutions to then just transferring the unprocessed film through a developer, and then now we're onto the proper technology of being able to send it.
Speaking of
But it's
technology,
cool, right?
yeah, it's way cool. Yeah. Do you use ultrasound?
Uh, no, but I see it evolving. It would be helpful in cases, but again, you gotta understand that this is another level of care that is added on what we already do, and that makes it difficult. There are these bedside ultrasounds. It would be it would be interesting to pilot a project for doing that within the communities, but we're not quite there yet.
Wow.
But we do have a pilot that's going around, like a pilot project where echoes can be done in community, but it's still in its wee stages there. We have yet to. It's a good thing to have, but it's it's still a work in progress.
Wow. That's definitely low-hanging fruit on how to improve outcomes to give you the ability to use ultrasound to rule out or rule in some sort of pathology.
Exactly, and you do mention outcomes, and that is kind of like what we strive to. Let's have better outcomes. Let's improve our patient care, and everyone knows that immediate care, especially in a trauma, you're on the clock. You're literally on the clock, and you need to do the appropriate interventions to get that client in a state where we can travel, or we can get them to a place where they can get the required emergency attention that we don't have. So there are so many levels to this, and again, it's the goal of improving patient outcomes.
So for anyone wanting to work in your environment, what can they do to get a job?
Because when I came up, I'm going to actually mention this. When I came up with pediatric critical care. I all my education was based on pediatrics, but then my education was lacked in adult care. So there was quite the obvious, like, that's something I really would have or should have had more of an experience on. The struggle with coming up here is that people need to identify this as a specialty. All right. So just like if you're going into med surge, just like if you're going to OB, and wherever those, like critical care, even ICU or pediatrics, coming up here is a specialty, and I don't recommend it for people that have just graduated through nursing school, because the thing is that your practicum itself is very new with all the available options that you have. I would strongly recommend that people have a myriad of experience, and to the main point would be to have a solid patient assessment skill, and to be able to to be able to understand the client as a whole. And if you have a really solid background on patient assessments, and I think that's something to strive for before coming up here, because the availability of all those wonderful options isn't here. So to be able to kind of be able to think the process through on your own, that's a definite must. We've had some people that have excellent training. Critical care and emergency, and again, pediatrics, but they really struggle with being in an environment where nothing, you're it. And that is a scary thought. So if somebody is interested in coming up here, to have the discussions with people coming that have been up here is good, and to know that if you have a person that you can connect with. But the basics of ACLS, ATLS, NRP, PALS, these are definite musts before coming up here. So I would probably recommend, one is just to get some experience under your belt, be it whatever place that you do get, but to have the conversations with physicians on as a whole, so you can get a better understanding of what you have to look at. It's not just a diagnosis. You have to look at differentials. And so having those conversations is definitely helpful before coming up here.
How many patients do you see in a day?
They've been doing counts for us, and it varies, especially when you have outbreaks. For it can go anywhere. I have to go by month because I that's the feedback, that I've gotten. I go from anywhere from 100 to, on a really bad month, 500.
That's a lot of people.
So that's a lot of communication with community physicians. It's a lot of communication with, NPs, and it's a lot of collaboration, and it's a fine, fine balance. By the end of the day, if there is an end to the day, um, you know, you're mentally exhausted, and anyone coming up here, even newer-ish, you are exhausted by the end of the day because you are learning exponentially when you come to a place such as mine.
Is this contract like a 5 week on, 5 week off, or how does it work?
Well, for me personally, I work full time up here. And, there's a lot of my colleagues that work full time. But we also have casual work. So it's really up to them. It's still in flux, sometimes 4 weeks, sometimes 2 months. It really depends on what the schedule of the healthcare professional has. And so, yeah, eh, we're working on job share, and some go 4 months on and 4 months off, and it really is it's variable. It's variable.
So, what is an interesting thing that your community does to have fun in the middle of the dead of winter?
Have fun. Okay, not freeze. I'm a little bit different. I love to knit. I like to learn. I have I have two wonderful cats. Um, uh, uh, there's also called, what is it, shop therapy. um, uh, that everybody has their own, or should have their own. Like, the people go for walks. We go on adventures when we can, and my colleague embroiders. I certainly don't have the eyes for that at all, and what she does is very, very teeny tiny, and I commend her for that. But yeah, it's just, you make what you have, and it's a lot of fun. I can make a really good latte up here. Let's say that too.
Anke, my final question for you is this. What advice do you have for the new nurse who is just starting out in their career in austere medicine?
Look around you. It's not about the numbers. You really have to look at the client. It's not just diagnostics. I think that's a that is a not really trained as much as when I was trained. Um, so look at the numbers. Don't look at the numbers. Look at the client, and trust your gut. If you're not, talk to your colleagues. Find that one person that that gets it, and latch on to their information, and be a sponge. And it's exciting. Don't just wish to be in a different area. Wish for constant learning, and have fun with it, right? Ask the questions. That's probably what I would say to nurses. Ask the questions. Talk to those retired nurses and ask them what it was like. That's what I would tell a new grad.
That's good advice. Thank you for being a guest on our podcast. It's been quite interesting to see how you do medicine in the far north.
Well, I appreciate the opportunity. So thanks again.
This has been a presentation from the College of Remote and Offshore Medicine. If you would like to earn CPD credits for this podcast, you can join the Council of Members. Being a member of the college gives you free CPD credit, free access to our virtual field guide, and discounts on our e-learning courses. You can join the team on our college website at quorum.edu.mt.